All right, how are you all doing today? Good? Any questions from last time? We just started, for those of you joining us, we just started on the hip and knee last time round. We did quite a lot, actually. We covered anatomy, we covered a little bit of the childhood syndromes, and we're diving right into osteoarthritis this time around. I think what I wanted to talk a little bit about before we get started is closed chain versus open chain a little bit. What do you do if a hip flexor is really tight and dysfunctional, and how do you get somebody to be in a better posture, really? And so I think we are going to cover that a little bit further down in the session. So we'll get to look at that a little bit more in detail. Things get complicated because of the two joint muscle versus the one joint muscle that we have going on with the psoas versus iliacus. But I think something that I will talk about when we get to the exercises too is I really like the idea of active stretching when muscles are really overly tight. So especially with the psoas, I find that counter the opposing muscles, getting the opposing muscles to fire really seems to help just get over that edge of this constant tightness and issues that we have at the hip flexors. A lot of times we focus on stretching and stretching and stretching, and then it doesn't last long enough. So sometimes I think getting them to the point where they're stretching, but they're also activating the opposing muscle group sometimes can really help release tight muscles. So we'll definitely talk about that more when we get to the exercises and when I start demonstrating the exercises. So keep that in your head. But if you do have questions, always feel free to email me, and I will do my best to email you back and answer any other questions at the beginning of our session when we join up again. Okay, there we go. Here, we're going to start in on osteoarthritis of the hip. It is a super big condition, so I've tried to keep it simple. We could go on and on. I'm sure all of you have clients that have osteoarthritis of the hip to some varying degree. There's a lot of reasons why people have osteoarthritis of the hip, and it actually ranges in age. I've seen people with osteoarthritis of the hip really young, meaning like 35, and then all the way up into their older age. So when we talk about the definition of osteoarthritis of the hip, we're looking at one of the most common causes of disability in the population, over 60. So it's a super common cause of disability. What's happening in the situation where we're having osteoarthritis is basically the cartilage is wearing down. So it's the cartilage that is covering the bony surfaces. So it's the cartilage in the acetabulum, which you can see kind of way up in the acetabulum, and the cartilage covering the top of the femur. And that's what's wearing down. Over time, we get inflammation, which actually progresses the process of deterioration, and then causes pain, right? The bone spurring, uneven surfaces, or unsmooth surfaces, I should say, and then pain and inflammation. So we also see a lot of joint space narrowing, and that makes sense, right? If we're wearing down the surfaces, there's more compression on the joint. Normal would be 3 to 5 millimeters. A mild osteoarthritis would be 2.5 millimeters ish, and severe would be less than 1.5 millimeters in the joint space. So really like halving or less than half when it gets severe. So you can imagine that would not be very comfortable. But what you can also imagine from this is that something that might be nice for them is to help them create a little bit of space in that hip joint, right? Just based on those numbers. If we can do things that might create a little bit of distance and a little bit of space, they might feel more comfortable. Okay, so what is the client presentation? Typically, the client presentation is somebody over 60. That is more common. Sometimes it has to do with a previous history of hip dysfunction or hip injury, and that's a little bit why I brought up those childhood diseases of the hip, was because those can be preceded by hip osteoarthritis. In fact, I think I told you the story that my brother had the Legg-Calvé-Perthes disease as a child, and they told him that he's likely to have osteoarthritis in his hip as an adult and perhaps need a hip replacement as an adult. So lucky for him, that hasn't been the case this far. but we'll see. He's only 50, so we'll see what happens when he's 60, but so far no hip pain. But those things can lead to a hip osteoarthritis because the shape of the hip in the socket is probably not exactly the same. Also, a history of high impact sports, and I would add to that sports where they're requiring a big range of motion of the hip. So those would be your dancers, right? I have a much more propensity towards osteoarthritis of the hip. Obesity, it's not shown to actually cause osteoarthritis, but those with osteoarthritis have a tendency towards obesity. So that is a big factor as well. And we also know that it can really, if somebody is obese and they lose weight, a lot of times the joint pain, even from osteoarthritis, goes way down. So I've had clients of mine who've been able to really postpone surgery because they lose weight. And just because there's less weight on the joint, so there's less pressure, there's less pain and less friction. Yeah. So what are you going to see in that client and how are you going to recognize it? You're going to see antalgic standing, which means anything we say is antalgic means of favoring. They're going to put less weight on the affected leg just because it hurts more. There's more compression. They're going to have that antalgic gait pattern. And a lot of times that gait pattern looks like a weakness of the glute medius, right? So it looks like their hips dropping out from under them. I call it kind of the runway model walk. And let me see if I can turn my camera here. I can show you a little bit what that might look like. For pretend, I don't actually have osteoarthritis of the hip, luckily. All right. So, you can't see all of me. Oh, maybe that was a little too aggressively low, sorry. Okay, you can't see all of me, but you can see my hip. So when you have somebody walking with an antalgic gait, what a lot of times it looks like is when they take that step, the hip just drops out to the side and then they collect again. So you might have a one hip drop out to the side. So if I did on this side, it would look like that if it was my right hip, that if it was my right hip. So a lot of times you'll see that sort of a pattern in somebody with hip osteoarthritis. So they also are going to have pain with internal rotation a lot of times. So if you take the hip and turn it inward, knee inward, then they're going to feel uncomfortable or pinching in the hip joint. Sometimes they say it feels like my hip is pinching, or the front of my psoas feels like it's getting pinched. That's often a complaint. And they might have pain with external rotation of the hip as well. And we do this Faber test, which is one of these tests in physical therapy that we actually bend and open out to see, kind of seeing what the joint feels like and if they can actually get that hip rotated open. So you could look at something really simply in our Pilates world. You could look at what happens if they put their feet together and let their knees fall open. Are they equal on both sides? Is it painful on one side? Can they sit cross-legged? Those are all things that are going to give you the similar kind of information. And it's nice when we get versus spine, which we were just talking about. With the hip, we've got two. So we can have a comparison. Some people are just tighter in the hips, as you all know. And so it's hard to know if you just look at the one side, if that's their normal or if that's because of an injury or something else. But when we have two sides, you can compare sides and have an idea, and at least a pain idea, and often that range of motion idea as well. What will a client complain of? A lot of times, and kind of that giveaway, is pain in the groin area and the medial knee area. So the groin is a big one. A lot of times people have they say they have hip flexor pain that doesn't go away. And I had a client that, it was a super interesting story because she was in her late 50s or maybe early 60s at the time. And she had a little bit of hip pain. And I said, let's go have that x-ray. Why don't you go check in with the doctor, see if they think it's appropriate, get an x-ray. She went and got an x-ray and they said, oh, there's just a little mild degeneration, nothing going on at that hip. And so I said, great, let's let's work. And for a year, we worked together and there was no more hip pain. She was doing great. And then I moved my location of my studio, and the place where I was that she was coming to see me, there was a flight of stairs, a big, like 18 steps up. And over the course of probably 6 months, she went from being able to just walk up normally to not being able to walk up the steps and complaining a lot of hip flexor pain. And this was really only 6 months since that first x-ray. And so I kept working on her psoas. I kept trying to release the psoas. I kept trying to fix her alignment, do all these things, and nothing got better. And I said, you know, I think you need to go have an x-ray again. And in 6 months, she went from almost no degeneration to full bone on bone, no more cartilage in her hip. And it was so fast. And so I thought that I didn't expect that big of a change in such a short period of time. So all that to tell you that sometimes when it seems like it's a psoas issue, a lot of times those symptoms are similar to what somebody's going to feel with a hip osteoarthritis. So keep that in mind. If you're working with somebody who's 60 or up, that's because that's just the most common demographic. And they complain of psoas pain, and you've been stretching with them and you do exercises that help them, there's no relief, then I would send them off and to see a doctor and perhaps let the doctor assess and see it could be a hip osteoarthritis, yeah? Especially if there's a family history. If their parents had osteoarthritis, if they had other parts of their body that might have osteoarthritis, that's a really big clue in. And in this case with this person, her parents didn't, and she didn't have any other osteoarthritis at the time. So pain walking up and down the steps, that's a big one. So that was kind of our giveaway with this particular client. Pain with sustained sitting, because as they sit, they get that compression. Then they have a hard time standing up as well after sitting a lot of the time. They also, pain with driving is a big one, and sometimes getting in and out of the car. They'll tell you that I have a hard time. I've got to pick up my leg with my arm to get in and out of the car. So the leg doesn't want to lift up after I've been driving for a while to get it out of the car. That's a really big complaint as well. They would also often have difficulty with balance on uneven surfaces or pain on a single leg stance. And so what are going to be our contraindications? So it's going to include end range of motion at the hip, especially in internal rotation. And we talked a little bit about internal rotation last time. And I was saying that I don't often exercise people in internal rotation of the hip. I just don't find it to be very functional. I do check range of motion and want them to be able to have range of motion at the hip, but to do exercises in it is not my preferred. And so with this population, you really don't want to do that because that's where they're going to be most painful usually. Heavily loaded leg exercises are going to be contraindicated, meaning this is not the person that you want to put on huge heavy springs on the reformer, and then even maybe a little bit less when they're in standing, because that's just going to compress the hip joint, right? We want to think about things that create length, not things that are going to compress. Exercises that create a lot of bounce or loading, like jumping, running, those are going to be not the best, right? Because they're just creating more impact all the time. We want to think about exercises, again, that relieve pressure. So swimming, spinning, those are really better exercises for this population. Deep squatting can really grind the hip. It can also wear on the labrum. And so if you have cartilage issues already, then you're putting more pressure on the other soft tissues around the joint. So you may end up affecting the labrum as well. All right, what should be the primary focus when we work with this group of people? Hip range of motion and lubrication. So what do I mean by that? We remember every joint has that synovial capsule, and we've got synovial fluid inside the joint. So if we can maintain range of motion or restore functional activities, that person is going to last a really long time. So I do a lot of feet and straps, but not on the reformer so much as on the Cadillac or the springboard or the tower. And the reason for that is that the legs are independent on independent springs when they're not on the reformer, right? Each spring is totally separate. On the reformer, they're on the pulleys. So if one leg does something, the other leg sort of comes for the ride, or the weight gets taken off the other leg if one does more. Whereas on the springs, you can really see which leg is doing what, and they can really work to have symmetry without having a pull or push from the other side. So that's a really nice one. Just really gentle leg circles. I usually use, depending on the weight of the body and the strength of the core, I usually use a little bit lighter spring perhaps, and work on the circling range of motion. That's my favorite. Frogs, circling. Frogs, you're not going to go super wide with those knees, but just in a nice controlled frog position. And I'll show you what I mean when we get to the exercises there. So that is one of my favorite things to get the range of motion and to get lubrication of the joint. I also like distraction. So distraction meaning opening the joint, things that create space in the joint and can potentially decompress the cartilage. And so those are things that you can do also with springs, but kind of in the reverse direction. A lot of times I use the bar, the wooden bar on the tower or the Cadillac to put their knees over to give them some length away. And again, I'll show you these, but things that are going to keep lengthening, things where they're hanging one leg down or extending it long and away. So that sort of cueing is going to help them find that space in the joint versus things that compress. Also working on alignment, trying to find and keep a good alignment for the pelvis and the lower limb. So one of the worst things that happens when people let hip osteoarthritis progress too far, these are people who are maybe trying to postpone surgery, they don't want to go there, but they're starting to have this antalgic gait pattern and they can't get out of it. They can't get good alignment. So what do you think is going to start happening here? They start hurting other parts of their body, the other side, the other knee, the low back, like all those things start to go downhill when they have this antalgic gait pattern and their alignment is off for long periods of time. So working with them, you do want to have them keep good alignment while they're doing the exercises, while they're walking, while they're doing functional activities. And when you see that they're so painful that there's no way they're going to keep good alignment, that's the point where I usually say, here's where you need to make a quality of life decision. Now it's really time to go talk to your doctor and see what else. Sometimes sometimes it's indicated that they get a cortisone injection, and that will take a lot of the pain away, and that will help them find alignment again. Sometimes it's not, cortisone injection is not appropriate, and so there's not much else to do other than progress to the next phase, which we'll talk about down the road here in a minute. So unweight and lubricate, that's my motto for osteoarthritis, especially at the hip. Yeah, it's easy little rhyme for you to remember. Okay, so exercises that might decrease pain, either for a non-operative person or a pre-operative person. So range of motion, unloading or that distraction idea, stretching the hip in all directions. So internal rotation, we're not going end of range. External rotation, we're not jamming down. We're not going to be pressing these knees down when people are sitting in butterfly, right? We're going to allow gravity to do some work. We want it to be gentle and kind of that longer hold, intentional stretch. We also want to stretch some muscles that cross the hip and the knee, right? So we did a tiny bit of anatomy that included that, which was rectus femoris, right? Sartorius, gracilis. Those are the three big ones that cross the hip and the knee. So that means quad, front of thigh, inner thigh, and sort of that diagonal thigh, which is kind of the frog out position is going to help sartorius go on stretch to frog with a bent leg. So you want to make sure that those muscles are really, and then the hamstrings in the back. You want to make sure that all those things are really well stretched out so they're not putting more compressive force up, right? So if their muscles are coming from the pelvis, like the ischial tuberosity or the ASIS, and they're tight, what are they doing? Right? They're compressing the joint more. So we want to make sure that those muscles are long and supple, so they're not just all the time compressing that hip joint up into the socket more. Yeah. We want to, again, create length. We can do traction through the joint, and I'll show you a couple exercises that can really help traction through that joint. And also they could have some manual work from somebody who does manual work. I do a lot of traction with my hip osteoarthritis clients using straps and belts and things like that. which wouldn't be something that you would do, but I can show you some exercises that you know well in Pilates that would effectively traction. So progression for the exercise is really going to depend on the stage of the disease and the path that that client is on. So if it's a non-acute or pre-op, you're going to have work to unload range of motion. You're going to work strengthening and functional positions for walking and movement around the house. So how can you mimic gait patterns? And then acute pre-op, so just really in pain just before surgery, same thing, really, range of motion. And then this is where I really think getting them in the water, the pool or aquatic therapy is really nice, because then they're unloaded and they can still work on range of motion without their whole body weight. And then light stretching, but this one I probably wouldn't do a lot of exercises that are loading the hip in standing. So taking their body weight off is going to be more helpful in this case. In terms of progression of the exercises in the order, I would say we would go more supine, then side lying, prone, kneeling, and then standing last, right? So we're loading, very slowly loading the joint as we go through the exercises. Prone and side lying, you could really switch around for that acute person. So it could be one and then the other. It doesn't matter so much that order, but then kneeling and standing start loading more and more. And kneeling versus standing, because then we don't have to deal with the alignment of the lower leg, right? We don't have to deal with the alignment of the knee and the ankle foot as well. So we can just focus on the pelvis, hip, low back. And then sitting last. What happens with osteoarthritis also is that it's this progressive degeneration that's going to continue. So there's really nothing we can do specifically that is going to stop the degenerative process at that hip. So when the cartilage is too damaged, a hip replacement is necessary. That's sort of the end result. And it just depends. It depends on quality of life. That's usually what I tell my clients is it depends on when your quality of life is such that you are limiting yourself in a way that's not ideal. That's when you should have the surgery, right? There's such a range. You could have the surgery when you know you have osteoarthritis, you have minimal pain. You could have the hip surgery when you're totally disabled and walking around with a walker, right? You can wait that long. I find that the clients that do best are the ones that are somewhere in the middle, more towards the milder side, in fact, because then their muscles haven't totally atrophied, right? If you wait really a long time, the muscles have started to atrophy. They've got this antalgic gait pattern that's then really hard to get them out of later on. So I think waiting till they need a walker and a cane, they can hardly do anything, is actually not the best approach always. Granted, you don't want to rush into a surgery if you have 5 years that you could wait, because the technology keeps improving all the time. And the longevity of the hip used to be about 10 years only. So then people were having revisions all the time. A revision surgery is not a very great, it never turns out quite as good as the initial surgery. So you really don't want to have to do a bunch of revision surgeries along the way. So, but I think now the hips are lasting a lot longer, and the technology we have is so much better that they're not needing revisions as often. So I would err on the side of, if you need the surgery, not waiting till you're totally disabled to have it. The options to prolong surgical intervention often include injections, manual therapy, joint distraction, movement therapy, range of motion, strengthening around the joint, and alignment and gait training. And the osteoarthritis in general, if you are strengthening and maintaining range of motion, you really can prolong surgery with minimal pain. So there's a lot that we can do as Pilates instructors to help them along the way and help them prolong it in a way that their life is not affected very much, right? So we have a lot that we can do here. Operative options, the primary thing, if it's really osteoarthritis, really you're gonna have a hip replacement. What they do is a total hip replacement, means that they're putting in a cup into the acetabulum and they're putting a new head on the femur. So they basically saw off the neck of the femur and they hammer in a titanium one, and they put a big stake down the femur, and then you have this new titanium ball of a femur. So no more bone, just that titanium. And then they put a cup into the acetabulum, and that's where how your joint functions. It's super cool that we can even do that. It really, if you've ever been curious about what that looks like, there are tons of YouTube videos you can watch hip surgeries on it. It just the way I think about it is it's like carpentry on the human body, right? It's a glorified carpenter, but there's sawing and there's hammering. And so if you're not up for that, don't watch that video. But it is really interesting how they do it. There's two main approaches. The old approach, or the original approach, was this posterior approach, where they would cut through the butt area, through the muscles in the back, right? So that already is not ideal, right? And then they dislocate the hip out the back, and then they put in that new hip and they sew everything back up. So people who've had a traditional posterior approach, which there are still plenty of people who have that. I think a lot of my clients who've had hip surgeries 20 years ago, that's what they were doing still. And the danger with that is that it can dislocate again posteriorly. So, and that usually so they have contraindications to movement, which would be anything that's flexion past 90 degrees. They can't go internal rotation, and they don't cross their legs over midline. And those precautions stay for the rest of their lives. Yeah. So because they're always worried that hip's going to dislocate out the back. And once that starts happening, and they have to relocate it, it gets really unstable, and that leads them a lot of times into a revision surgery. So remember that hip flexion to 90 degrees can be actual hip flexion, so actually bringing the knee up towards their chest to 90 degrees, or it can be trunk flexion forward to get that more than 90 degrees. So it's not just bringing the leg up that makes that angle more than 90 degrees. It's bringing the trunk down. So forward bending to the floor with the chest towards the thighs, it can go past 90 degrees. So that's something to be aware of as well. But we are seeing that less and less. Now the posterior approach, they have a new one that's a minimally invasive posterior approach, meaning they don't cut through all the muscles. They just do it's a much smaller scar. They dig in around the muscles and they move them out of the way, and they still do the same posterior dislocation to do it. But those people actually don't have precautions for life. They have precautions the first 6 or 8 weeks, and then they're able to go on about their life. The ones that I like the best, or that are easiest for me to work with, are the anterior approaches. That they're going in through the front of the hip. The danger there is that there we have, and I didn't show you this in the anatomy, but we have a huge femoral artery and nerve and vein in the very front of the hip. So the initial surgeries, they felt like it was quite dangerous because they have those structures there. And if a surgeon was to cut those structures, you'd lose function in half your leg, right? But I have never seen that happen. And the difference here is they cut in the front, they dislocate it anteriorly. So they're not going out through all the muscles in the back, which is great, because then when they put it back in, you actually have no precautions ever. In the very first weeks, you're not supposed to go prone extension or extending the hip behind you, but that's like just to let the tissues heal. So that's really 6 to 8 weeks of no extending the leg behind, no big motions inward or outward. But those, once you're healed up, you don't have any more precautions, right? And a lot of times the doctors will try and hide that scar kind of under the bikini line if women are self-conscious. You don't have to have a huge scar as you do with the back. So I kind of already described this as a removal of the head and neck of the femur and cap covering the acetabulum. It's usually the anterior approach or the minimally invasive posterior approach now. And we already talked about the traditional ones. And so this is what it looks like. The bone is prepared and cut. So you see they've cut off the whole head and neck, and then they put in the prosthesis. That prosthesis travels down into the femur, quite a ways down, like a little spike. And then you can see it has a cup in the acetabulum as well. And so that head just articulates, rolls around in the cup there. There is another hip surgery they can have, which would be a hip resurfacing. And here they only remove the head of the femur and the cap, but maybe not the acetabulum. So if there's not a lot of cartilage dysfunction in the acetabulum, they may preserve that. It could be just as invasive, spares the neck of the femur because they're only replacing the cap, a very head of that. It's only appropriate for more active younger populations. Usually men in their 50s and 60s are the best candidates for that. It's harder to do it on women because they just have a bigger Q angle. So somehow that makes it harder to seat the cap into the acetabulum, and the lower bone density. So the bones have to grow in and hold that cap on. So sometimes for women that's harder because of lower bone density in general. There is a higher risk of fractures at the neck of the femur after this surgery as well, but it's easier to revise and do a full hip, total hip arthroscopy if later on they need that. So if there's a question as to whether or not the person actually needs a full hip replacement and that maybe they can preserve some of it, then this might be a good option. But then knowing that if it doesn't do enough or if the osteoarthritis progresses, they can go into a full hip replacement later on. And that would be a much better revision type surgery than having a hip replacement and then having it redone later on. Okay, and so here's kind of what that hip resurfacing looks like. You can see that we still have the bone here preserved and then the cap. And then here's what the full hip replacement would look like with this all shaved off and then the cap in the acetabulum. And with the resurfacing, they can choose to put a cap in the acetabulum as well. It would be the surgeon's choice as to what they felt like was better. Okay. Oh, sorry. Going back. Oh no, go back. How do I go back? Oh, I gave away my little thing. Okay. So again, we said that acute post-op is going to be same exercises as we talked about the pre-op. So post-op, this exercise is going to be the same as the pre-op, but with a walking program right away. So these people are getting out of bed the next day and learning how to walk again. So they're not staying in bed for very long at all, and they're getting up and walking, which is fantastic. Non-acute post-op is going to be return to full functional activities. When it's never really recommended that they take up high impact sports. I do know some people who do end up running again after hip replacement surgery. I'm not sure if I would recommend that. Spinning, cycling for sure, hiking, walking for sure, running is just a lot of impact. So I would have to probably check and see what a surgeon's opinion is, but I think it's probably not the most ideal. But you can, when they're strong, they can do it sometimes, right? So I just wouldn't make it the everyday exercise. Okay, and then a little note about gait here. I thought this was really funny because they're all watching her gait pattern, I'm sure, as she goes by and nothing else. But I think it's super important to reassess gait, to look at how they're walking, because that can be significantly affected. And so here, I just super brief review on gait pattern, right? So here we have the phases of the gait cycle. We actually have two phases in our gait cycle. We have the stance phase and we have the swing phase, right? And we always measure gait on a single limb, right? So you can pick which one you want to look at. All of the diagrams, all of the explanations, always take the right leg. But it can apply to the left leg. You would just look at the left leg through stance and through swing phase, both, right? And we have a bunch of different phases phases within each phase. Weight acceptance is that initial heel strike. We have, and that's in the double limb support, so both feet on the ground phase. Then we end up with the single limb support stages, which would be mid stance, so pre-stance, mid stance, terminal stance. And then we end up with the limb advancement phase or the swing phase. And here in the middle, we have a little double leg support, and then we have single leg support. So we have stance phase on the right leg, then we end up in swing phase with a double leg support moment in between each. Yeah. The difference between walking and running is in running, we have times where we have 2 feet off the ground. In walking, we always have a leg on the ground or a foot on the ground. So, and then just to remind you that with the hip and the knee, with the gait cycle, in order for it to be normal, we need to have enough range of motion to make a normal gait pattern. You can't have a normal gait pattern if the range of motion doesn't exist, right? So with a hip, we need the max extension that we need in terminal stances, 20 degrees. And we need flexion and swing phase, active flexion to 25 degrees. So you need at least these minimal measurements in order for us to have a normal gait pattern. For the knee, we need 0 in terminal stance, meaning we need to get to full extension of the knee in terminal stance, and we need to get to 60 degrees of active flexion in the swing phase. So that is going to be more relevant when we talk about the knee, but it also, a lot of times people freeze their knee when their hip's not working right. So it would be worth it, even if you're working with somebody who has a hip surgery or hip replacement, that you pay attention to also make sure the knee has enough range of motion. Okay, I'm going to pause. Are there any questions?
I not a question, but just something that's frustrating is when you do have clients that come into a group situation that have been, let's say, triathletes their entire life and have gone through hip replacements, and they don't want to, you know, you have to teach the lowest common denominator, but they don't always want to listen to your suggestions for modifications. Then what do you do? I mean, granted,
Yeah,
you know, it's frustrating because you know that they're doing things that aren't helpful for their long-term functionality.
yes. You shaking your head. We know this situation very well. This is a big problem, and it's people who, it is that athletic population, and they don't want to back off even if you recommend something. And you know, the people that you need to be most worried about are the people who have had a posterior approach to the hip with a fully invasive posterior approach, so that sort of original posterior hip. And they're, like I said, they are still out there.
Right.
And it's a really, I don't know that I have a good answer to that question, because I have failed in that category myself, where even with my advice, they don't want to follow it. I have a group of people going, and they're doing things they really shouldn't do.
Right.
And
you know,
so,
try to steer them to privates, but you know, not, especially that personality type. I think they thrive on even though it's not supposed to be competitive, they like to exercise in a group setting. So
yes, they do. And they compete. And if they're not competing with the next person, they're competing with themselves.
Exactly.
So, and there's always that attitude of, well, nothing's ever happened to me before, so why should it happen now? And so, you know, I think based on my own experience, in retrospect, I think I would actually be pretty firm. And if you're really concerned about the person, I would say you are not to do these exercises. My past approach was really, it's your choice, it's your body, and here is my recommendation, and I'm going to leave it at that. And I have other people to attend to, and I can't focus and worry about you. But I think in my retrospective view, my approach would have been much more firm. Like, this is actually medically contraindicated for you. And if you do these exercises, you're putting yourself at risk, and I can't be responsible for you in a group setting. If you need help and advice, I'd love to do some privates with you. Or I think when I give you a cue, you should really respond to that, because I'm just trying to keep you safe. You know, and I think I would have taken that firmer approach now in retrospect to my own personal experience. I tend to be a very soft person, and I want to allow people to be and live a little bit. But I feel like that with that personality, it needs somebody stronger coming back at them with the same, like, you're putting yourself at risk, and I can't be responsible for you in that setting. You know, I'd love to help you. I'd love to get you stronger, but this is actually doing you harm. And I would say that it's not just in the hip population. The other population that really frustrates me is the lower back, the lower spine population. People who have had their back pain, they're like, oh, but I've had this all my life. It's no big deal. and you're in a class, I know, and our studio, all our group classes, we keep them what we call back safe. So we're not doing things that we're really going to herniate a disc but in a regular Pilates class, which people are entitled to have, and some of you teach in places where you do that, there are people showing up to those classes who have disc herniations, disc bulges, and they want to do short spine stretch, and they want to do all those exercises that everybody else is doing. That's another place where I think really in my consciousness, I would have to say to them, you are going to hurt yourself, and I don't want to be responsible for that. So when I ask you to modify so I don't have to see you hurt yourself. And so please modify. And if you don't want to, know that it's on you, and that you're really risking hurting yourself. So I think, unfortunately, that personality, I think, really needs that. So low spine and hip, I would probably take the same approach. And those would be the biggest two categories. So yeah, thank you for bringing that up. And I'm sorry I don't have a better solution for that. I'm going to keep going here on for a little bit longer on labral tear. So what are we talking about when we're talking about a labral tear? We're talking about that fibrocartilaginous ring around the head of the femur as it's entering into the acetabulum, right? And that I talked to you about it being sort of that suction cup that pulls the head of the femur up into the socket. It also provides shock absorption. It seals the joint that contains the synovial fluid, helps maintain equal pressure across the head of the femur, stability and pressure distribution for the joint. And it also deepens that acetabulum. So it really seats the head of the femur in there. A tear is when part of that ring pulls away from the acetabulum. So it can look like this. Here's what your normal labrum should look like in this ring here and the head of the femur here. Here's what can happen when you have a labral tear. So it's a part of it kind of tearing away from the acetabulum here. And here's another view of what it might look like. So it's just pulling away from the actual acetabulum. And then here they can actually go in and repair it where they have to staple it or stitch it back to the acetabulum itself. What really causes a labral tear? Sports injuries that have a high impact on the hip might be a cause. Also trauma, especially if there's a trauma that includes a hip dislocation. And that could be a lot of times a car accident or a big ski accident, something that it would take a lot to do that. It's most common in athletes that are soccer players, ballet dancers, ice hockey, football players, and actually in golfers. Why do you think in golfers? All that swinging of the hips, and that rotation, which we actually encourage movement at the pelvis and the hip because we don't want it in their low spine. So there you have a little balance there. Structural abnormalities of the hip itself from a previous injury or any insidious reason would make it more likely to tear. And sometimes it's also associated with osteoarthritis, femoral acetabular impingement syndrome, or capsular hypermobility. And we're going to talk about FAI later on, so I'm not going to dive in right now. And hypermobility of the capsule itself, where it's just really loose to begin with, would make it more likely or more easily tear. What do the clients complain of? So usually they complain of anterior hip pain that's kind of constant and dull with an intermittent sharp pain. So if it pulls away at moments, that's where they're going to get a little more sharp pain going on, but they're going to have this sort of constant aching at their hip. It will definitely worsen with activity. It will probably have pain with walking and definitely with pivoting motions where they're moving the head of the femur in there. It can worsen with prolonged sitting. They might have some clicking or locking of the hip, and they might have a range where they circle the hip and there's always this one place where they feel like it catches or it clicks or it locks, different than when the psoas clicks, right? And it usually has pain associated with it. They might feel like the hip is giving way, right? Because it's not as stable for sure. If the labrum's not as stable. And they usually have pain at night, some stiffness in the hip, and groin pain as well. Sometimes there is, instead of that anterior hip pain, you can sometimes have a gluteal or posterior pain. And that's the difference between an anterior tear usually and a posterior tear. And we'll look at those in just a moment as well. And sometimes there's no pain at all. So most often this is wear and tear, right? Insidious over time tearing that's happening. And this is actually a really important point, is that it's often undiagnosed or misdiagnosed for an average of 2 years. So labral tears go undiagnosed a lot. And that's really unfortunate, I think, because there's people suffering from hip pain for a long period of time, and they go and have an x-ray, because that's usually first protocol, and the x-ray shows nothing. Because the x-ray won't pick up a tear in the labrum, only an MRI will, and sometimes even an MRI doesn't pick it up. So they often are living with this, not knowing what it is, thinking they have a muscular imbalance or something for a 2-year period of time before it's really diagnosed. So that's unfortunate. Okay, so presentation, demographics. Presentation and complaints are really that clicking of the joint giving way. They might have a limp or that Trendelenburg gait, which is where the glute is dropping, like I showed you earlier. Pain in the gluteal region would be less common in the Western world. It doesn't always show up in an MRI, so sometimes they need an MRA, which is they use a dye in order to see it, for sure. It happens more in women than in men. Most common age is 15 to 41. So it's not as the same demographic as the osteoarthritis typically. In client presentation, a lot of times it can be because of a imbalance in the pelvis and back that can increase the forces on the labrum. So Lisa, am I describing your dancers now? But a lot of dancers have that issue, right? Because they have a lot of dancers, people with scoliosis, those are people who have that imbalance in the pelvis and back that can put more pressure on the labrum. There is, I bring in this Jonda's lower cross syndrome just because I think it really talks a little bit about how things interact with each other. I'm super superficially talking about it. So if you're interested, I would recommend that you look it up and do a little bit more reading. But just to give you an idea, when we have a muscular imbalance in the pelvis, that usually means tightness of hip flexors and lumbar erector spinae muscles. And then what you get from that is a weak inhibited gluteal and abdominal muscles, right? That imbalance usually leads the body to move in an anterior pelvic tilt. So that would be ASIS going forward, low back going into a bit of hyperextension, and then increased hip flexion, right? So if your pelvis is anterior, you're going to have a shortened hip flexor region, so shortened anterior hip. You can stand up and try this if you like to see. That increased hip flexion makes increased weight bearing on the anterior acetabulum and the labrum, predisposing it to tearing. So if corrected, they can have a greater distribution. So you're basically trying to distribute the force not to the anterior acetabulum, but all over the acetabulum, so in the full socket and then across the labrum instead of consistently on one spot of the labrum. So these are, dancers, gymnasts often have that hypermobility stance where they're anterior tilted, they've got excessive lumbar lordosis, but what you can think about then is that they're pressuring the anterior acetabulum constantly. And then if they're jumping and landing and dancing and moving in that posture, doing gymnastics, like landing from flips and stuff in that posture, they're going to be more likely to have those anterior forces. And then those people tend to be also hypermobile a little bit. And so they have less stability already. And so it's an easy tear over time. Okay, what happens what are some interventions? Physical therapy. So what we're trying to do is create good movement patterns. You really want to address the whole body, right? So again, here's where you guys are rock stars as Pilates instructors, because we don't just look at the hip, right? We look at the posture above it. We're going to look at spinal posture positioning. We're going to look at tight muscles. We're going to look at balancing out low back versus abs. So all those things are super fantastic helps. to get somebody to feel better and to distribute their weight better across the acetabulum. Sometimes injections into the joint space they use in order to differentiate diagnosis and decrease inflammation. So what do I mean by differentiating diagnoses? Sometimes if they can inject into an area and be very specific about it and the pain goes away, they then know that that was the source of the pain, right? So sometimes people can have something going on. They do this all over the body, and it's not 100% certain what is causing the pain. So they'll do a trial cortisone or other steroid type injection to that specific area, and that will help decrease. If they get a decreased pain, they know, aha, that was causing the person's symptoms and pain. If they get no resolve, then they can go, that wasn't the source. Most likely that's not the source. Now that's not 100% true every time. When it doesn't resolve the pain, it leaves questions. When it does resolve the pain, you can be right on that is really the source of the problem, and then they can really address that problem. So we use that a lot in medical science. Because MRIs, remember, are only about 80% accurate. So that's something to keep in mind. We think MRIs are the be all end all, but they're not always 100% accurate. You can have an arthroscopic surgery for a labral repair or debridement. Arthroscopic is nice because they're not cutting anything open, right? They're just making 3 holes, 4 holes, 1 for the camera, 2 for tools, 1 for the drain, right? So you get these little tiny holes that look like nothing, but they kind of burrow in, get to the area, and actually do the surgery that way, which is fantastic. They can also have bone grafting done if the bone's been affected as well, in order to get that labrum to seat back on there if it's been torn away. Rim trimming with labral repair, so they can actually trim it down to take if the tear is very small and it's just a little piece of it hanging out, they can just cut away it and smooth the surface, and sometimes that's just fine. They can do any bone sort of changes. They can restructure bone. Now it's amazing what they can do to create a proper surface to seat better in the acetabulum. Oh my gosh, I'm running over again. Okay, we can start with exercise contraindications next time around. All right. Well, thank you guys again for being here. I really appreciate having you on. And if you have questions during the week, just send me an email. And otherwise, I will see you all next week.